So we move now to the complex cases session. We have 4 cases. These are much shorter presentation, but we have longer time for the discussion. We start with 3 cases from Dr. Antonio Bouts from the Netherlands. We're going to have 7 minutes for each case and then 8-minute discussions.
Okay.
Thank you.
Thank you very much for presenting these cases. The first one, so I have 3 cases. One is on congenital nephrotic syndrome, the second is a child with PTLD, and the third one is a child with a bladder agenesis. And the first child presented with asphyxia after birth and was admitted at the hospital because of an hypothyroidism. Came out of the screening, and furthermore she had an enterovirus meningitis. And she was readmitted 2 weeks later. She had a red purple spot on her back, and it came out that there was a subcutaneous fat necrosis. But in that workup, she suddenly had an hypoalbuminemia, and then they checked the urine, and she had proteinuria, and we found out that she had a nephrotic syndrome. And the ultrasound of the abdomen showed that she had already a thrombosis in the renal vein. So she was treated with ACE inhibitors, anticoagulation, and levothyroxine, and later she received a line for albumin and furosemide infusions. And so during her follow-up, she received 2 times per week or 1 time per week albumin infusions, and we got the results of the genetic analysis. So she had an MPH1 mutation, and she had several re-implantations of the central venous line, one because of an occlusion and the second one because of an infection. And she had a gastrostomy because of her feeding difficulties. So here you see the serum creatinine according to the time. This is the last measurement at the moment. She has a GFR of 20 now, but she still has a very low albumin. And in the workup towards transplantation, father is going to donate his kidney. And we were discussing what to do next. Her growth is acceptable, maybe it's not so clear, but her height is at the -2 SDS, and the growth is the right figure. And now in our group we had a little disagreement what to do with the native kidneys. And there's recently a study where they compared the nephrectomies with conservative handling. And that's what we discussed in the group. So there were several options, and I was wondering what the group here advises us to do. So the first thing could be continue with the albumin infusions weekly, and then perform a preemptive living-related transplantation when the albumin gets higher than 20, or intensivate the albumin infusions, because every time she comes to the hospital, her albumin is around 14, so she really goes down quite quickly, and or going to nephrectomy, unilateral or bilateral. So that's my question to the audience.
Any takers? Bilateral, unilateral nephrectomy. Can we ask Nikos at the back? Any views?
Yeah, I think we had a case recently, and we did bilateral nephrectomies robotically, I think, by the paediatric urologist, and then did a live donor transplant about 6 weeks later. It wasn't quite for the same reason, but it was very nephrotic and had a low albumin, and that I don't know if that's what we would do routinely, but that's what we did in Leeds quite recently. He's doing okay.
Is there somebody who changed his policy? Because that's what we had. We previously were conservative, then we changed to more aggressive nephrectomies, but because of the last publications, we go back to more conservative handling.
So I think as a unit at GOSH, I'd say we are more conservative over the last 5 years, so we don't give as much albumin infusions necessarily if they're not running into problems. So that's the first point. The second point is about now that your GFR is 20 and you've still got massive proteinuria and hypoalbuminemia in a patient who's already had thrombosis, we would think that the changes in the risk of thrombosis post-transplantation and peri-transplantation are increased. So personally, we would do bilateral nephrectomies and have had a live donor. And as you said, you can do the live donor within about 6 weeks of PD in the interim. I know the Evelina have had a policy where they did unilateral nephrectomies. We had a trial of doing that about 20 years ago, but we never found that we, in our cohort, that we had any advantage. You're only buying a little bit more time.
This is not my policy, it's our nephrology policy say you are the last resort, you are the end of the train. So they try every single medical aspect, cyclosporin, they're very aggressive cyclosporin, they Prograf, infusion, and if that fails, then I come and do total nephrectomy and PD. And I would not do a transplant anytime soon. I would do a transplant probably 6 weeks later, 2 months later, until all the nutrition replacement, all the coagulation factors are back to normal, then I'll do it.
Does that answer the question?
Yeah, thank you.
Great. Should we move to the next case then?
I can tell you what the plan is. We will perform unilateral nephrectomy, but I mean it's maybe the middle way of all the options. Then we go to a second case in a child after kidney transplantation who received an aneurysm, and so she's now 10 years old. But her history is quite big. She had a steroid-resistant nephrotic syndrome. She was treated with steroids, CNI, plasmapheresis, rituximab, ofatumumab. She had no mutation. At the age of 7 years, she received a living-related kidney transplantation from her grandfather. And she was negative for EBV and also negative for CMV before transplantation. She had a direct recurrence of her primary disease, and until now, no remission was achieved with, now I think we tried everything, we'll show it later. She had a primary CMV infection, and therefore the immunosuppressive medication was adjusted, and she ended up in a rejection episode, which was treated with methylprednisolone and plasmapheresis and IVIG. Last year, she had a seroconversion of the EBV, and her viremia was not so high. She had maximally 5,000 copies per ml. And somewhere in the summer, she had recurrent abdominal pain with fever. And firstly, she was treated with antibiotics. She recovered. Antibiotics were stopped, and the abdominal pain recurred. And then finally, the surgeon decided to perform a laparoscopy because they didn't understand what was the problem, and ultrasound didn't give us a solution. So this is the course of her treatment. You see here. Oh, this doesn't work. So at the left graph, you see the proteinuria, and with the black line, and at the right figure, it's also the proteinuria. You see that she's still very high nephrotic, and we tried now all therapies. Even she had LDL pheresis before transplantation, but didn't work in her case. And so she ends up now already with a very bad kidney function. So her creatinine, here's almost 300, but I think at the moment it's around 250. So she has already a bad kidney function. So the surgeon removed an infected duplication kyst. That's what was the macroscopic conclusion, and sent it to the pathology. And we got this result. So this is the ileum, and here you see the villi, and so they did all kind of staining. So here they found that there were lymphoblasts with single or with multiple nuclei. The CD20 staining was positive. The EBER was also positive. There was another staining, which is a measurement of proliferation activity marker, is also positive. And but there was one problem, that the material was not kept in only saline, so we couldn't perform, we couldn't give an answer on the clonality of the material. So we ended up with, is this a PTLD or a diffuse large B-cell lymphoma, or is it just a primary EBV infection? Because in that time, she also had made her seroconversion. So we ended up with performing a PET scan, so to look if there was an increased uptake, but it was negative. And then together with the oncology department, we decided to not continue with imaging or another treatment, but just go on with monthly treatment of monthly ultrasound performances for 1 year, and keeping the immunosuppression level not so high, so the TAC level around 4, and the prednisone quite low. And she was for 1.5 years totally fine. EBV PCRs were negative, no abdominal pain. And then in the last summer, she had an upper respiratory tract infection when she was on holiday, and she came back, and the mother told me that her rhinitis didn't recover, and she also didn't hear well. And we performed the ultrasound, and then there were some lymph nodes again at the right lower quadrant, and the EBV PCR was a little bit positive. So all these things together, we thought, there is maybe something going on according to these possible PTLD. So she went to ENT doctor, and firstly he wanted only to place the tubes in the membranes, but we insisted to also perform an adenotomy, because I thought that might be in the localization of the PTLD. So it was performed, and then we go again to the pathology pictures. So you see here the adenoid overview, and just to compare what is normal, here you see all this follicular architecture. So there's really a disorganization of the material, and this is a more close-up picture. And we did the same stainings, and there were again lymphoblasts with 1 or more nuclei. CD20 was again positive. The EBER was again positive. Now that's all the same, and also the proliferative activity marker. And when we look to the follow-up of the EBV, you see this was the last year when we performed the laparoscopy. And so in that time, she had the seroconversion of the EBV, but always very low EBV viral loads in the blood. And so we ended up with, it is a PTLD, and it's a diffuse large B-cell lymphoma. So when you look to a schedule from a study from Dierix in the New England Journal of Medicine, she is now classified as a monomorphic PTLD, and the treatment is always reduction of immunosuppression, so that's what we did. And the second one might be rituximab, but my question in the group is how we have to perform this treatment, because it's difficult now to look what's going on in the nasopharynx in imaging. So an ultrasound of the abdomen is very easy to perform, but what to do with the imaging in this area is quite difficult. So she had the PET scan, and the abdomen was negative, but the sinuses were both full, but maybe only with mucus, but we don't know. And the CT and the MRI showed an enlargement of the adenoids, which is suspect for, again, the lymphoma, or it's not removed totally. And there were also retropharyngeal lymph nodes. So this is her creatinine. So she is already in a bad situation according to her kidney function. And my questions to the audience is, what shall we do with the immunosuppressive therapy? So the azathioprine is already stopped. The tacrolimus, we went down to a trough level of 2 to 3. But yeah, when we stop properly, she will get a rejection of the kidney, but she is already in a bad kidney function. So maybe we have to go on with this. Or do we have to give her a chance of a longer remaining of her kidney, transplant kidney, and switch to the mTOR? There's still an adenoid in the nasopharynx, so do we have to remove this? And when do we have to start rituximab? What will be the interval? Because she had allergic reactions, or you suggest another treatment of this difficult PTLD?
Wow. Okay. Any ideas? Any suggestions?
I think that in our center, we consider this a life-threatening situation. So the kidney, I don't care about the kidney anymore. I think I was surprised that immunosuppression is still going on, number one. Number two, if you have that in our center with this multifocal already, we've been chemotherapy because we don't think that rituximab offer the best treatment for long term.
Thanks. Obviously, a very difficult case. Do you think that had you known, do you think, had you been able to get an idea whether this was monomorphic PTLD back when the surgeon did the laparoscopy, you might have modified your treatment plan? The reason I ask is that there are actually kits that you can use to get DNA and RNA out of formalin-fixed tissue, and sometimes clinical labs are not aware. It's just an extra sort of set of extraction columns and triazolization. So sometimes if you've got these difficult cases, you can actually say, no, even though it's not in cellin, you can still get genetic information out of a sample. Do you think that might have given you a bit more guidance earlier on, or do you think it wouldn't have made any difference?
Yeah, I think definitely when I had this result last year, I think I already would stop the azathioprine and continue only with prednisone and tacrolimus. But pathologists, told us that there was no option to have more material for getting this information on a monomorphic or polymorphic PTLD. And then it's because we had also another child with he got a tonsillectomy, and but that was more organized in the pathology preparations, and he also had a primary EBV infection. So that was the difficulty. Is this EBV just but infection only, or is this already PTLD? Because it's a spectrum. But when I had more information, I definitely would change I had changed the immunosuppressive schedule last year. Yeah.
So I think I agree with Valdo. This is a multifocal disease, so I think you should proceed with the chemotherapy and proper treatment of the cancer that you have here. Just want to share our recent case in a child who had simultaneous liver and kidney transplant 20 months ago, who incidentally was found to have PTLD in the colon and underwent colonoscopy because had a low albumin 12 to 16 months after the transplant, and the child was from the very early on a minimal immunosuppression, tacrolimus and daily prednisolone, so we stopped MMF very early on because of the high EBV count. And our monitoring includes some of the things that you do, which is abdominal ultrasounds for those who have high level of EBV, and we can debate what a high level of EBV is, LDH and blood film. And it had actually, so we caught a unifocal, we think, disease in this patient. So he remains on tacrolimus immunosuppression only, but we have given him rituximab actually, and his EBV count has come down. We've killed all the B cells, so EBV count has come down. He's still early on. He just completed treatment in September to see what happens. But I think, I just wonder if we didn't maybe give rituximab and acted on a focal condition, whether in a year's time we would end up with a multifocal disease as well. So that's what we've done for that one in the bowel.
Okay, thank you.
I just want to say that some of these cases are after you treated chemotherapy and they're stable, these are the patients become tolerant. We have had some patients over 10 years with immunosuppression. We had 2 patients. Hopefully we don't get this many cases, but it's something that not necessarily because you stop the immunosuppression, you're going to have rejection. There are some of these that they stay and be tolerant.
Just one last question. Just to clarify, the initial surgical intervention was laparoscopy rather than laparotomy. Was there a subsequent conversion to laparotomy, or was it all done laparoscopically?
All done laparoscopy.
Okay, that's interesting. Is it just from a surgical point of view, in a child with suspected abdominal PTLD, what would people do? Would you go for laparoscopy first and then convert, or would you go straight for laparotomy? It's a 10-year-old child.
Yeah.
And the weight is how much?
Her weight is 20,
Okay.
around 30, between 25 and 30 kilograms.
Any views?
Probably would have done CT, I think. I got the impression that CT wasn't done, it was an ultrasound and then laparoscopy. Is that right?
Yeah, that's right.
Probably would have done CT.
Yeah, our radiologists very often say that they have enough with the ultrasound. They don't like CTs in children, so that's the discussion we have. Yeah. more than, yeah.
Yeah, so we would have done an abdominal MRI with potentially a CT chest at that point. I mean, it's obviously easier to be wise after the event. We wouldn't have done a laparoscopy from the cases that we've had. We go for laparotomy, and I would have stopped the azathioprine at that point, even based on the histology you had of the ileum. I think there was enough there because we know that EBV, viremia, the actual number is not a reassuring that you're not going to develop PTLD, but having that amount of proliferation on the histology from the ileum would have meant that I would have given daily pred, TAC, and stopped the azathioprine at that point.
And you would change to mTOR, because that's what the Heidelberg policy is now. They changed the PTLDs to from TAC to everolimus.
Nobody knows.
Okay.
Those TAC, stop the TAC while you. I think if you're going to give chemotherapy, then you should stop the. I would stop the TAC and continue with daily prednisone, but not have an mTOR or TAC.
Yeah.
We're definitely not impressed.
The oncology doesn't want to start chemotherapy now. They first want to give rituximab. So I will stop the TAC. Yeah.
Great.
Immunosuppression, you gotta deal with this head-on, but you want to stop immunosuppression, you don't stop immunosuppression. And I think that this is an over-immunosuppression type of disease. So it's a concept you have to have, whatever mechanism it is, you gotta deal with it.
Great, thank you very much. So we'll move to the last case, if that's all right.
So the last case is a child who was antenatally already known that she had an oligohydramnia, or more an anhydramnia, I think around 20 to 23 weeks of pregnancy. She had a solitary multicystic pelvic kidney, and there was no bladder filling. And postnatally, there was an unclear gender, so definitely a very severe genital malformation. She was 46XX, so a female, and she had directly after birth, or within a few days, she had end-stage renal disease. There was in the beginning some urine production, but not that much. So she started with peritoneal dialysis, but we had technical difficulties. There was a peritonitis, but she also had. It looked like that the dialysate came into the urine because we sticked it with the glucose, and we thought there is some strange connection in this abdomen. So we stopped with the PD and we changed to hemodialysis with a central venous line, and no shunt, no fistula. And so then we did, the urologist performed a vaginoscopy, and they found a hypoplastic uterus with a small, besides a small opening, which ended in a kind of a cyst. And I will show you one of the pictures with two hypoplastic ureters. She had some genoplastic operations performed. And we never understand her anatomy real. So this is the contrast filling here from the vagina, and then we had these. Yeah, it was like some. It was more like balls above each other, and. But we do not know exactly how the anatomy was. We performed MRI, all kind of imaging techniques, but definitely she had no bladder. And she was doing well on the hemodialysis. And at the age of 2.5 years, she got a deceased donor kidney transplantation. And we didn't perform an augmentation because she was anuric. So she had the transplantation with a ureterocutaneostomie. And she was negative, not negative, or positive for the EBV and CMV. And she got our regular immunosuppressive treatment with the twist schedule, but we didn't succeed in stopping the steroids because she had all kinds of side effects and recurrent infections, but relatively few urinary tract infections. So that went quite well with the STOMie. But because of all these infections, we reduced immunosuppressive therapy. She had a lot of viral gastroenteritis episodes where the MMF was stopped, and later she was switched to azathioprine, but in between she had a rejection. And at the age of 5 years, which is now, she has a creatinine of 85 with a GFR around 47. And but our discussion questions are about making a new bladder. And I remember when she was a baby, we discussed it with the urologist and the surgeon, and we planned to perform a new bladder formation before the age of 4 when she goes to school. And because that's an important thing in Holland, that you like the children are continent when they go to school. But it is postponed. She's now 5. And the reason why it was postponed is that, the urologist was afraid of getting obstructions, and she's doing well in her kidney function, not often a urinary tract infection. So she has still no neobladder at the moment. And my other question is, what options for the reconstruction would you suggest? Yesterday it was already proposed with the colon and ileum together and the Mitrofanov or other options. And what would your advice be in the timing of this operation?
Any views? Yelena is telling me that Nikos should comment.
Well, I mean, we'll have the urology team commenting on this case. Obviously, they will have been under their care for a while, and they will have had a plan. So obviously, it needs some sort of bladder, so to contain it for the urine and a drainage system. So yeah, I think it needs a neobladder and a Mitrofanov, and the timing is, well, I guess now, 4 or 5 years. And as long as the kidney is working well, good urine output, yeah.
Would you perform it earlier after transplantation, for example, 6 months? Or, I mean, that's what my idea was, just to perform the transplantation, and then 6 months later the bladder reconstruction.
That was an option as well, but obviously we're beyond that now, so yeah, do it now.
We've had a few cases like this at Gosh, and Claire might want to comment as well. No, she. But exactly. Our urologist wouldn't do it early. We would consider doing it around 5 years with school. But we've also found that some of our families actually don't want it because they get used to this life with the ureterostomy, and if they're not having infections, they're not running into problems. It actually takes more time to persuade them to proceed to actually doing the neobladder. But I think if the family are on board and your urology team are, then this would be the time going to school.
But that's what the reason was from the urologist that she was doing. That was before the rejection episode. She's doing fine. We have no infections, and just wait and see. But I'm a little bit worried about her psychological development because it's quite a wise child, and she needs many genital operations, and then she's incontinent. So I think when she goes to school, she will get problems, and she goes to a normal, not to a special school, but to a normal school. So that's why I thought it would be good to do this. It is a risk maybe, but perform this before the age of 4.
Do you think they've been psychologically disadvantaged, Claire? It's difficult, isn't it? With the families are so enmeshed, so it can be difficult to tease out.
Yeah, I think that this is not very simple in the sense that if you're going to do vaginal reconstruction, it's going to base with ileum. But it's an abdominal procedure because you have to replace it, if that's what you're going to do. I don't know all the details. Mm-hmm. So I don't think there's any rush to repair, put a Mitrofanov and all that until you figure out all the other anomalies first. And then you probably plan everything together. If she's doing well, as a matter of fact, I was very curious, the infections, because we are publishing right now for ATC our experience with cutaneous ureterostomy for transplant, and we just don't see urinary infection unless they're partially obstructed. So.
Great. Thank you very much.
Thank you very much.
And thank you for that tour de force of challenging cases. Thank you. So next we have Mr. Vlad Shumejko presenting the last case of the morning.
Good morning, thank you very much. This is the only case we eventually managed to refer somewhat reluctantly to London Guy's unit from Scotland in many years. So, some background. This is a case of 4-year-old girl with Alagille syndrome and bilateral renal dysplasia. She had quite numerous other problems: diaphragmatic hernia, peripheral pulmonary stenosis, not surprisingly difficult venous access because of multiple cannulations, even cardiorespiratory arrest due to tazocine reaction. Not surprisingly, very difficult fluid management, and she's currently basically not eating orally, but is on 3 boluses of feeds through the long-term nasogastric tube and overnight low-rate infusion. And she has portocath in situ, and central veins are still usable. Obviously declining renal function. At the age of 10 months, the liver failed, so she had left lateral segment liver transplant performed in King's College unit, followed by 2 consecutive repairs of diaphragmatic hernia, the last one with a mesh. She has adrenal insufficiency, mom is single, and this girl's brother also had liver transplant, so mom is kind of torn between the cases. She is small. That's a trajectory of her growth on growth hormone, and she's currently almost 17 kilograms. Liver transplant was performed with basiliximab induction, and she's currently on 3-agent immunosuppression with excellent liver function, and somewhat surprisingly, left lateral segment is remaining in as if left lateral segment position. You would normally expect left lateral segment to migrate in the normal position and assume the classical liver position, but it's not in this case. It just got stuck there, presumably because of multiple re-explorations through the rooftop incision. The other thing is that the option of gastrostomy is virtually impossible. It's quite well covered and hidden by this liver. And if you look carefully at the images, there is kind of obvious discrepancy. The proximal small bowel is quite distended, and there are also collapsed loops here and there at the distal end. So there is a degree of subacute bowel obstruction, if you want. It's not complete, because contrast eventually makes its way through, and she's still thriving, but there is a worry that adding another organ into the presumably right side of the abdomen with existing subphrenic adhesions, intraloop adhesions, may just tip the balance and distort the bowel to such an extent that it may go into complete bowel obstruction. That's a consideration. So, issues. Do you think it's safe to transplant her on the right side, or would you consider transabdominal approach? Bowel seems to be adherent to the diaphragm, and whether we just transplant extraperitoneally, hoping that it won't affect the GI function, or should we just go intraabdominally and divide all the adhesions? We considered live and diseased donor transplant, and diseased donor transplant seems to be kind of less predictable, and probably you wouldn't want this operation to be done at 3 o'clock in the morning. Mom has mismatches against the liver, whether we should accept those, probably. And mom also has renal artery, which is kind of traversing the cruise of the diaphragm, basically arising above the expected level. Another question, would anyone use basiliximab for induction again? Would you use basiliximab more than once? Thank you. Yeah, I've already discussed all those. So in communication with the liver transplant unit, we had a strong advice that liver surgeon should be ideally available on a short notice, and this was the sole reason for us referring to Guy's unit. Yeah, thank you.
Great. So which question would you like to start with first?
Just can we...
The basiliximab question.
Basiliximab, would you use it more than once, and
Yes.
what would be the protocol?
Yes, we've used it just recently on that patient who had a transplant when we were having surgical challenges meeting. She's doing absolutely fine. We would use it. 10 milligrams for those who are less than 20 kilograms and 20 milligrams for those, you know, heavier than that.
Would you be afraid of potential adverse reactions which are described, or less effective second use because of pre-existing antibodies and elimination of basiliximab?
In the circumstances where we've used it, we really had no other options. We had children losing their dialysis access, and on the other hand, some infectious complications. So I think for her, you have liver there as well. I know it's not the same donor, but it will give you some immunosuppression as well. That's my opinion. So.
Valdo, would you think you would try to avoid mismatches with the liver, or would it not matter?
I stick to same blood type if I can, and I like thymoglobulin.
Thank you very much. That's all.
One other question.
Would you like
the mother's renal artery? How would you do that differently for the live donor?
I think that'll be okay. We just need to get as much of it as we can. We've printed the abdomen, the kidney at the back. So those of you who want to have a look, you've seen the CT scans, and you can see what the 3D print looks like. And yeah, I'm sure it would be fine to do it in Glasgow, but having a liver surgeon who can be here in 20 minutes is useful.
Yeah, I spoke to Hector Melendez, the surgeon who did the first transplant, and he was quite under the impression that he would like to be present. Yes. For whatever reason. He must have done something.
Maybe he signed the liver.
Can I? Sorry. Thanks, Vlada. It's a tough case. I just wanted to ask you a question about what the vessel's like. So the cava, the iliac arteries.
Oh, they would be considered fine for transplant. I would normally go on the right side extraperitoneally and lift the whole thing, find the IVC, find the aorta and implant it there.
Yeah, I suppose, I mean, that's what I'm wanted to ask, and it's probably good to get Nizam's opinion on it as well, is just the fact, that's what I would do, as well as the fact simultaneous live donor. I think the mismatch would probably be secondary to the fact you've got a live donor, because you'd want to explore it during the day, have a liver surgeon present, know the vessels are okay before you remove the kidney from the donor. That would be, I think, the biggest thing for me. But I would probably just ask Nizam, because I know they do a lot more sort of intraperitoneal complex. What would be your approach in this kind of situation?
I think for this one, I'm kind of veering towards the retro approach, just as you say. The last time I did a retro approach for a small child was in Glasgow in about 2001.
I'm happy to join if you want.
You're very welcome. But I think it'd probably be easier to do it that way. And you know, there are plenty of people who do all their small children retro. We tend to do them intraperitoneal.
Okay, you've got, Nizam, you've got the kidney there and it's working, but patient is still unable to eat. Would you consider some form of feeding, enterostomy, any of that, to combine with the transplant?
Yeah, I mean, that's a difficult question. We went through a period of doing feeding jejunostomies for our pancreas patients. And actually, when we looked at that, the number of complications was very high, and it didn't really seem to be the thing to do. So, so I think doing it at the same time, probably not. But
so you would stick to nasogastric long-term
well,
tube feeding?
We could have a PEG. We could do a PEG.
PEG seems to be kind of not a very easy to do option anyway.
Just a quick surgical question for my clarification. So this patient has features of subacute small bowel obstruction, is that right? I mean, if they were an adult and you were treating them analogous to a patient who's had a right hepatectomy with bowel up under the diaphragm, you'd go in and do an adhesiolisis. Was that not maybe an opportunity whilst doing the kidney transplant to actually mobilise the bowel off the diaphragm? And
it's kind of,
it's
yes,
a short-term solution, but that's what you do with the
the train of thought is that you would normally try to leave as least problems for future as possible, and by placing kidney extraperitoneally, you're kind of committing not to do that at that stage. Maybe just leave it for chance and deal with it as and if it arises, I suppose.
But I guess this patient's at risk of acute small bowel obstruction if they've got
very significant
subacute bowel obstruction symptoms already.
How does a nasogastric feed work if you've got bowel obstruction anyway? How does that get around the problem?
Small boluses and some vomiting in the morning. Ian, you can comment on this as well, yeah? So she's kind of absorbing some of it, but she's vomiting pretty much regularly if you overdo the volume of infusion, especially in the morning, after overnight eating.
She's definitely going to be supplemental feed dependent. She is one of these patients who we've saved their veins because we can't actually cannulate them.
Endure the risks.
So is the plan to bring Hector up to Glasgow or vice versa?
Yeah, Hector was very keen to come to Glasgow and have another go on caviar sandwiches, which we used to have long ago. But last minute it changed somehow, so he cannot come to Glasgow. Too busy in London here.
Fine. Thank you very much. Thank you.